All right. This is a lecture that is going to be focused on cranial nerves. Um, One thing that I want to point out with making this video is this is what the name is indicating here, a general overview of cranial nerves. Um, I definitely have ambitions in the near future to make a more comprehensive video in the anatomy about the anatomy of these cranial nerves, in terms of their projection pathways, where they enter and exit the cranium, the exact details associated with the cranium. For now, I'm just keeping this as a more general overview, just talking about the basics of where these cranial nerves are rooted. What I want to focus more on is the functions of these cranial nerves and some basic clinical applications of impairment or damage to these cranial nerves. Like I said, I will make a more detailed one down the road. So in saying all that, my goals for this particular lesson or lecture are A, just to describe the key but basic differences between a cranial and a spinal nerve. Um, and then obviously you have to understand how the cranial nerves are named and the roles that they play in bodily functions. Another key thing with cranial nerves as well is identifying in understanding their functional characteristics is understanding if a cranial nerve is sensory, motor, or mixed. I'll talk about what that is more in a moment. And then, like I said, with anything, if you understand how something works, it's important to understand what happens when it doesn't work and the effects that damage or impairment to cranial nerves will create within the body. Um, so let's talk real briefly about just some basic differences between cranial nerves and spinal nerves. Obviously, cranial nerves are called cranial nerves because they're rooted within the brain, meaning they project to and from the brain. Versus spinal nerves, they are rooted within the spinal cord. So information, when I say information, sensory and motor information that we're dealing with the spinal cord is going into and out of the spinal cord directly. Versus when we're talking about cranial nerves, when we're talking about sensory and motor information here, we're talking about information going directly into and out of the brain through these. All right. One thing that's very interesting about spinal nerves, even though there's a lot of homologous characteristics to cranial and spinal nerves, the fact that they're paired, there's sensory, there's motor aspect, there's roots to these, there are some key differences here as well. When it comes to cranial nerves, information flowing through cranial nerves is going to be both somatic and visceral sensory, and also somatic and motor as well. Um, and we'll talk about that more when I get to the more of an overview of the basic anatomy of a spinal nerve. Versus when we're dealing with cranial nerves can be just purely visceral or somatic sensory, or visceral or somatic motor, or they could be mixed in nature. Some cranial nerves are purely sensory, some are purely motor, some have both characteristics to them. Versus spinal nerves, you're seeing both sensory and motor information moving through those. Um, they're found in pairs. Both types of nerves are found in pairs. But like I said, you're looking at more functional pairs with cranial nerves. Um, and the cranial nerves are usually named based on some anatomic characteristic or functional characteristic. You notice the spinal nerves are more named based on anatomic characteristics, and being that there are just so many more spinal nerves, and there's obviously a complexity to them and how they're organized, you tend to find what are called plexi associated with spinal nerves. I always like to describe plexi as like organized maps of nerves that project away or to or away from the spinal cord. And again, I'll show what those are more later on in detail. But you tend to find that with spinal nerves as well. All right. Now, when it comes to cranial nerves, as I mentioned previously, cranial nerves are rooted within the brain. Um, and therefore they deal with mostly sensory and motor functions with the head and the neck. There are a couple of exceptions to that, but like I said, we're talking about functions of these nerves. Like I said, head and neck. Um, Now, when it comes to the nomenclature of these, cranial nerves have just an actual name to them, and they are also numbered with Roman numerals. And I'll show you how in a moment. And like I said, cranial nerves can be identified as sensory, motor, or mixed. It's important to understand that because when cranial nerves are damaged or their functions are impaired, it's important to understand if they are motor, sensory, or mixed because, for example, if a cranial nerve is damaged and it's pure sensory, then obviously a sense of the head is going to be affected by that. If they're pure motor, then some kind of physical function associated with the head is going to be associated with that, like with impaired eye movements, impaired inability to speak or swallow properly, or so on. And then when we're dealing with mixed nerves that have, when we say mixed, we're saying some cranial nerves have both sensory and motor projections associated with the head or the neck. So if those nerves are damaged, you could see a combination of both sensory and motor functions damaged, just depending on what the nerve is, what the branching map of the nerve is, where the nerve is damaged, and so on. Things are a little more complex than that, but you get the gist. All right. Now, let's take a look at cranial nerve organization and how they're named. With the naming part of it, or nomenclature, as I mentioned, cranial nerves are typically named based on a particular function that they can carry out. Like, for example, if we look at olfactory, olfaction is just a high class term for smell. Optic, that's just a fancy word for vision. Oculomotor, that literally means eye movement. Those names are obviously associated with functions associated with the head. Olfaction, detecting odors. Optic, analyzing, sending visual information to the brain. Oculomotor, eye movements. Versus when we look at nerves like the facial nerve, that's more telling you the distribution of the nerve around the face. I mean, that's not a hard one to process there. For saying facial nerve, that's a nerve associated with the face. Glossopharyngeal nerve, that's telling you that there's distribution from that nerve to the tongue and the pharynx, i.e. your throat. Even the word vagus, the vagus is Latin for wandering, and I'll explain the relevance of that when I get to that nerve. So as you can see, like I said, these nerves are usually named based on either functional contributions to the head or the neck, or like I said, as some anatomic characteristic or map associated with that. And then also when it comes to numbering cranial nerves, every name has a number in the fashion of a Roman numeral associated with it. And the way cranial nerves are numbered, they are numbered from rostral to caudal. Remember, when you're using the word rostral, that's just saying towards the front of the brain. Caudal means towards the back or towards the cord. And so basically, the olfactory nerve is the most rostral of the cranial nerves. And remember, when you look at this here, when you look at this picture, going back to what I said earlier, cranial nerves are found in pairs. So whatever you see on one side, they will be homologous on the other side. So being that the olfactory nerves are the most rostral of the 12 pairs, therefore olfactory nerves would be classified as cranial nerve number 1. Next in line would be the optic nerves, which would be classified as cranial nerve number 2. Ocular motor is, next when we're going caudally, so that would be cranial nerve number 3, and you can get the gist of this as we continue to go, down the brainstem towards the spinal cord. All right, and you can see right here that this is an actual brain that they're illustrating this on as well. So, like I said, cranial nerves have just a name, and they've got a Roman numeral that's tied to that name. It's very important that you understand both, especially because, like, moving forward, like after this, there's some of these cranial nerves are going to pop up quite a bit, none more than the vagus nerve because of its involvement with the autonomic nervous system. And most of the time, I usually refer to it as, that one I usually refer to as the vagus nerve. But some of these, I don't know, I just, some people have a tendency to call them cranial nerve number this, cranial nerve number that. So that will tell you, by understanding the numbers, that will help you understand the anatomic organization of these nerves. And then the names also will help you understand the anatomic characteristics or functional characteristics associated with them. Now, there are 2 pairs out of the 12 pairs that are not rooted within the brainstem, and that would be the first 2 cranial nerves number 1 and 2, or olfactory and optic, respectively. The remainder of the cranial nerves have roots within the brainstem, and again, when you number them, going from rostral to caudal, rostral basically meaning more towards the brain itself. In this situation, caudal meaning we're getting closer to the cord itself. That they're numbered in that fashion. So as you can see, as we go down the brainstem, that has to do with the nomenclature of these. All right, and let's just dive in and start talking about them. Cranial nerve number 1, the olfactory nerve. But olfactory, remember, that's just the fancy term for smell. Olfactory, the olfactory nerve, see, you'll see why I have this S here in a moment. But the olfactory nerves, these are purely sensory in nature, and these deal with smell. Um, Now, in saying that, also just for a moment, when we say that this is pure sensory, this is what's classified as a specialized sense. Usually, when we break down senses, remember when you hear that, whenever you hear the word sensory, always think input, meaning a nerve ending somewhere in the body that is detecting a stimulus within a tissue environment. Remember, a stimulus is the technical term for an environmental change. Detecting a stimulus and then projecting that information in the form of action potentials from peripheral parts of the body into the central nervous system so we can process it. All right, so sensory input. Now, when it comes to sensory nerve endings, there are some that are very generally organized, and there are some that are highly specialized in terms of how they're organized. When we say special, basically general senses, general sensory nerve endings like temperature, touch, pain, there's just not a lot of like tissues surrounding them to help support their function versus special senses have a lot of support in terms of allowing them to understand stimuli in the tissue environment. Like, for example, when you learn vision, you'll learn that with vision, most of the anatomy of the eye is very little of it is neurological in nature. Most of the anatomy of the eye, you're learning about connective tissues, you're learning about muscles, whether it's smooth or skeletal muscles, you're learning about fluids. And and basically the neurological components of the eye are the retina and the optic nerves. However, even though there's at the gross anatomic level very little neurological things to learn, what is there is ridiculously complicated and important related to vision. Same thing with olfaction. When we're dealing with olfaction, there's a lot of epithelial tissues and mucosal secretions that support how these nerves actually work. So these nerves, so basically, when you think special senses, these are nerve endings that are embedded within a lot of tissues that help them do their job. Um, and as I mentioned, olfaction and odor. They project through what are called the olfactory foramina of the cribriform plate. Remember that the cribriform plate is at the roof of the skull. Hey, idiot. Not the roof of the skull, roof of the nose. Sorry. Um, but and we'll see it. We'll look at that in a moment. And obviously, if people have damage to this nerve or nerves, they will have an impaired sense of smell, or it could be a total loss of smell as well, which is called anosmia. All right. Now, if we look at this image, right here, if we look right here, that's the cribriform plate. Which again is the roof of the nose, not the skull, you pinhead. And remember, residing atop the ethmoid bone on the cribriform plate is a bulbous neurological structure called the olfactory bulbs. And then remember, the cribriform plate is very porous, and those foramina or pores are called olfactory foramina. So basically, the cranial nerves, olfactory nerves 1, project through those foramina and generate action potentials or signals to the olfactory bulbs, which you can see here in this little more clear-cut image on the right. Now, again, this is why I put the S in nerves, because you can see there are many, 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 many nerves here. And like I said, these nerves are embedded within, epithelial tissue and mucosal secretions. And I mean, realistically, if you want to boil down smell for what it is, obviously we primarily breathe through our nose, and when we inhale air through our nose, we are going to be inhaling, components of that air in, meaning, molecules that are in the air. There are certain molecules in the air that when we inhale them, that some of those molecules could stimulate these nerve endings. Remember, in order to get a nerve to fire an action potential or a signal, a stimulus has to irritate those nerve endings into generating action potentials. And those molecules that irritate these nerve endings that allow us to detect odors, those are called odorants. Um, so basically, when you inhale an odorant that irritates and stimulates these nerves, what they will do is they will start generating action potentials up through the cribriform plate to neurons that are within the olfactory bulbs. And later down the road, you would learn that olfactory nerves are what are called first order neurons, and then the nerves in the olfactory bulbs that project to the brain are called second order neurons. Now, an interesting little side note about olfaction and smell. This is from an evolutionary perspective, this is a very old sense. And the reason why I say that is because when you learn more about senses, if you're on the chapter on like the brain and central nervous system, you haven't gotten to like somatic senses and sensory pathways and stuff yet. But when you do learn the basic anatomy of the brain, one of the things you come across is the thalamus. Remember, the thalamus forms the upper walls of the third ventricle, which is part of the diencephalon of the brain. And the thalamus is what's oftentimes classified as the gateway to the cerebral cortex. Um, saying that sensory information that we need to send to the cortex so we can consciously analyze and perceive that information has to go through the thalamus first. Now, what's interesting about this, these olfactory pathways actually bypass the thalamus on the way to the brain so we can analyze that information. So that tells you of the age of that sense. This is an old sense of ours. And there's a lot of olfactory pathways that go to the limbic system of the brain, which you would have by now learned that the limbic system is the emotional part of the brain, where we deal with like raw fear, raw anger, using emotions to generate learning and memory type situations. So again, this is a very old sense in that regard, and the fact that it just completely, circumvents the thalamus. All right. And like I said, again, if people have damage to this nerves, now again, anosmia or is not always damage to cranial nerves. If people do, take trauma to, their head, or inhale chemicals that damage these nerves, yes, that's going to cause an impaired sense of smell. But because you have to remember, there has to be central processing as well. If there is damage to the areas of the brain where we process odors, but the cranial nerves are still intact, we're still going to have an impaired sense of smell. So the point I'm getting across here is that an impaired sense of smell isn't always damaged olfactory nerves. Like I said, there could be central origins to anosmia as well. All right. Cranial nerve number 2. And like I said at the beginning of this video, I'm keeping this intentionally basic. Like I said, I'll go more into the anatomy and these projection pathways down the road. Like I said, I want to focus more on the basic functions here. Cranial nerve number 2, the optic nerve, another purely sensory nerve that deals with optics, which means vision. Now, most of the fibers from the optic nerves that project towards the brain are dealing with our sense of vision, actually analyzing what we see, photo information, photons, wavelengths of light that enter the retina that we begin to formulate images from. However, though, there are some projections to the brainstem that allow us that basically are telling the brainstem about the amount of light that's entering the retina. Like pain pathways and whatnot that help us control the diameter of our pupil, and also help us control, how we're trying to accommodate and focus on objects. So the majority of the optic nerves are all about dealing with vision, but there's a little bit of, like I said, information about the intensity of light entering the eye as well to allow us to undergo pupillary reflexes to how much light is coming in. Basically, what the optic nerve, you want to boil it down to what it is, it's a huge collection of axons from what are called ganglion cells of the retina. And I'll get more into those when I get to the chapter on senses. But ganglion cells are cells in the outer part of the retina that gather at an area called the optic disc. They're axons, I should say, gather at the optic disc. The optic disc is where the axons of these cells gather, and that's oftentimes nicknamed the blind spot because there are no photoreceptors on that part of the eye to analyze light. So it's called a blind spot because we can't actually process images there. And optic nerves project from the optic disc to what's called the optic chiasm, and I'll show you that in a moment. Now, when people obviously have damage to the optic nerves, they're going to have an impaired sense of vision or total loss of vision if the nerve were completely cut. Now, the key thing about that, though, is the visual impairments associated with damage to the optic nerves are going to be ipsilateral, meaning they're going to be on the same side, meaning the same eye that the nerve is connected to or projecting from itself. That's important because when you get to the chapter on special senses and you learn more about this visual projection pathway, you'll learn that with each eye, there's nerve fibers from half of each side of the retina called the nasal and temporal sides of the retina that project through the optic nerve towards this optic chiasm right here. Now, That's important because, like I said, if you were just to completely cut this optic nerve right here, there would be a total loss of vision ipsilaterally on the eye the same side. Now, the optic chiasm is important because, well, actually, let's just throw a little piece out there. A lot of you probably heard a basic thing said, that we see the world upside down and the brain flips images around. There's some truth to that in the fact that we do actually sense the world upside down on the retina, but we perceive the world right side up when our visual cortex and our occipital lobe processes information from the eye. Remember, technically, when we're processing photons or light rays that hit the retina, we're not consciously seeing anything there. We're just analyzing basic information about shapes, colors, basic detailed, depth of light within our environment. Um, and yes, we do actually sense the world upside down on the retina. Um, I guess to explain that, when I first started teaching, for some reason my school didn't let me order parts from a company, that specialized in embalming specimens, and then schools would order for them for dissection. But yet they would allow me, they would fund me to go to there's a butcher shop nearby that butchered very large pigs, and what I would do, the cool thing about getting those specimens from those was they were fresh, they weren't embalmed. The drawback of that is they don't last long, so there's kind of a a race to use those. But at the same time, the nice thing, especially when it comes to eyes that come fresh out of the specimen, there's no decomposition with it. There's not enough decomposition to notice, because by the time the companies are using chemicals like formalin and other things to preserve the eyes, by then there's going to be decomposition of the internal protein structure of the lens of the eye, which is going to cause it to become very cloudy and tough in appearance. The cornea is going to become very heavily clouded over, and light just doesn't pass through these structures very well, so you can't really see through them. Now, when I had these fresh eyes, what I would do is I would have my students make a coronal cut towards the very front of the eye. I would have them grab the top part of the eye and actually hold it up to their own eyes and look through it from the back, to the front, almost like a first person perspective. And the lens would, this clear curved object would still be embedded within the ciliary muscle and the zonular fibers or suspensory ligaments that hold it in place, and it was clear, so you could still see through it. Now, because of the strong curvatures of the cornea and the lens itself, when light passes through these multiple curved objects, depending on the angle that light is passing through, a lot of light that's coming into the eye is actually going to cross over one another. And when light hits the retina of the eye from those light rays that cross, we will actually sense things upside down. And what I would do to illustrate that point, when students were holding the eye and they could see through the lens, you could see the entire room reflected on the very back of the lens. What was cool is everyone in the room was actually upside down on there. Now, the brain doesn't flip images around when that visual information is being sent to the optic chiasm crossing over. What happens are half of the nerve fibers from each eye, to be specific, from the nasal visual fields of each eye, actually switch sides, and then we form what are called optic tracts, which project towards the thalamus, so the thalamus can relay that information to the occipital lobe so we can process that. This is where the image is actually turned around right here. Um, because remember, one thing about the brain that you have to understand, the brain can only perceive or process information in the fashion that it's received. So because these nerve fibers switch sides like this actually helps turn the images around. And so the brain can perceive the world right side up. So we sense it upside down, but we perceive it right side up. Hope that makes sense. And then right here, this is, God darn it, stinking pad. Sorry, I'm using an old school tablet here for this, but this optic foramen right here is what the optic nerve passes through, which is part of the sphenoid bone, which the optic nerves pass through to meet and form the optic chiasm right here. And that optic chiasm is a very important part of the brain to understand, because that's a part of the brain where the hypothalamus is directly superior to it or above it. And so, and remember the hypothalamus is the main control center of the autonomic nervous system, and so many bodily functions are tied to that. That's a part of the brain you return to a lot in chapters moving forward. So just remember that, and plus the pituitary gland is directly behind the optic chiasm, and again, that's so therefore this optic chiasm and hypothalamus is an area of the brain that gets referenced very heavily. Or when you learn about the circle of Willis, when you're in the circulatory system, blah blah blah. Anyway, you'll understand when you get there. So the optic nerve, vision. Cranial nerve number 3, oculomotor. The name oculomotor literally means eye mover. All right. With this, so this is a purely motor cranial nerve, and with this, there is both somatic and visceral motor projections of this nerve. Remember, when we say somatic motor, you're referring to more superficial areas of the body. Usually, I teach my students when you hear somatic, think like skin and muscles. So if we say somatic motor, we're saying nerves that branch to muscles in the skin. In this situation, ocular muscles that deal with eye movement. When you hear the word visceral motor, those are nerves that project, that send signals or information to the deeper parts of the body. Think more like internal organs or more internally. So when we're talking about visceral motor branches of the oculomotor nerve, we're talking about going to the internal aspect of the eye and controlling various internal functions. Versus when we say somatic motor, we're talking about innervating ocular muscles on the outside of the eye that play roles in eye movements and allowing us to focus on objects. Excuse me. The roots of the midbrain are roots of the midbrain, dummy. Roots of the oculomotor nerve are within the midbrain and with what's called the oculomotor nucleus. And there's another area sort of within the oculomotor nucleus called the Edinger-Westphal nucleus. Now, the oculomotor nucleus is on the rostral part of the midbrain, remember towards the front. It's rostral to the aqueduct of Sylvius, or more generically, the cerebral aqueduct. I'll show you that in a moment. And then the Edinger-Westphal nucleus is on the dorsal part or the back part of the oculomotor nucleus. So think of it as like a nucleus within a nucleus, a brain center within a brain center. Now this, the Edinger-Westphal nucleus, this is where you have visceral motor projections, and I'll talk about that in a moment, versus the ocular motor nucleus overall is where you get the somatic motor projections. Now, when the ocular nerve approaches the orbit, it branches into inferior and superior divisions. The superior division innervates what's called the superior rectus muscle and the levator palpebrae superioris muscle. That's a muscle that helps deal with movements of the eyelid, the upper part of the eyelid to be specific. The inferior division has various branches. There's a medial branch that innervates the medial rectus muscle, a lateral branch that innervates the inferior oblique muscle, and then there's branches that meet with what's called the ciliary ganglion. Because again, you haven't gotten here yet if you're flowing with this correctly, but when you're dealing with the autonomic nervous system, the sympathetic and parasympathetic divisions, there's what's interesting and kind of weird in a good way or cool way about the autonomic nervous system is all the pathways are not all, the majority of the pathways are in the form of two neuron chains. So when we're talking about, mostly when we're talking about sending signals away from the brain and spinal cord through cranial and spinal nerves, we're talking about, one nerve that's sending information back and forth. When we're talking about, not one nerve, one neuron, we'll say, when we're talking about autonomic nerves, you always have two to send a signal, for example, from the brain to an internal organ through the autonomic nervous system. There has to be two neurons connected to one another to send that. And where the neurons meet peripherally outside of the central nervous system, they meet in what are called ganglia. So you're going to have what's called a preganglionic and a postganglionic neuron that we use to communicate with organs via the autonomic nervous system. So this ciliary ganglion, around the orbit, this is where what are called preganglionic parasympathetic nerve fibers meet their postganglionic nerve fibers, and those postganglionic nerve fibers project into the eyeball and help control what's called the sphincter pupillae and ciliary muscle. The sphincter pupillae muscle helps control the diameter of the pupil. It causes pupillary, and when we're talking about parasympathetic control of this, the parasympathetic nervous system causes pupillary constriction. And the ciliary muscle is a muscle that controls the curvature of the lens, and when it relaxes, it causes the lens to become more convex in shape, meaning more outwardly curved, which is very important in accommodating near vision. And we're looking at objects up close. When people have damage to this nerve, they will experience what's called diplopia, double vision. They'll have a difficult time moving their eyes to focus on structures in their environment. They will have dilated pupils, and they'll have what's called ptosis, drooping of the eyelid, and then the eyeballs will deviate due to the fact that ocular muscles will lose control over the eyeball itself. Now, let's talk about that a little bit. So if we look here, this is a really generic map of the midbrain right here. So basically, if you look right here, this is the aqueductus sylvius that carries cerebral spinal fluid through the midbrain from the third to the fourth ventricle. And rostral to that is what are called the ocular motor nuclei. Okay, so rostral meaning towards the front of that. Now, on the caudal, or the very back part of the ocular motor nuclei, are where you find those Edinger-Westphal nuclei. Okay, and that's where you find the parasympathetic outflow or the parasympathetic preganglionic nerve fibers to those muscles I just described. Now, when we're looking at the projections from here, notice how these nerve fibers pass through the red nucleus and substantia nigra on the way out. And so these nerves project anteriorly away from the brainstem, like all but one cranial nerve tends to do. We're talking about especially the output side of it. And this right here, when we look at this basic ocular motor nerve map, you can see that there is a superior division and an inferior division. And innervating these various ocular muscles. And right here is that ciliary ganglion that I mentioned. So this right here would be the end of the preganglionic nerve fibers, and this would be the beginning of the postganglionic nerve fibers, the two neurons that signal structures. And like I said, if people do have damage to this nerve, especially these inferior branches, then what could happen, like I said, that'll cause the pupils to be blown out within the eyes. I say blown out, I mean dilated, because they'll have a difficult time constricting that when those nerve fibers are damaged, and they'll also have a difficult time accommodating near vision as well. All right, so that's the ocular motor nerve. Cranial nerve number 4, trochlear nerve, purely a motor nerve. It is rooted within what's called the trochlear nucleus of the midbrain, or the mesencephalon, region of the brain that we classify as the midbrain. This is a funky cranial nerve in the fact that this is the only cranial nerve of the brainstem to exit the posterior aspect of it. All the other ones go out the front of the brainstem. And this innervates one ocular muscle called the superior oblique muscle. And the way this muscle attaches to the superior part of the eye, when this muscle contracts, it causes your eyeballs to rotate inferiorly and laterally, meaning downward and out to the side. Damage to this nerve will cause diplopia, again, the fancy word for double vision. And the interesting thing, it'll also cause the inability to look down. Or at least correctly. Like when I say an inability to look down, for example, think like let's say you're sitting in a chair and you've got like a book in your lap, and you tilt your head down to look at the book. Our eyeballs are going to rotate downward with our head so we can actually focus on that. What's going to happen when that nerve is damaged? When you try to tilt your head down, the eyeball will not actually be able to turn down, and it's going to deviate. It's going to deviate laterally. Now, what's going to happen is that's going to cause the person to tilt their head to the side where the eyeball's deviating to straighten out their visual field because their eye can't rotate downward correctly. When they're trying to, so like for example, someone had damage to their left eye, or the left oculomotor nerve, and they were unable to rotate that eye downward and laterally correctly, and it deviates like that, they're going to tilt their head to the left while looking down, just simply so they can focus properly on that object. All right, if that makes sense. So, like I said, there's the trochlear nucleus, also rostral to the aqueductus sylvius, or the cerebral aqueduct, and like I said, innervates the superior oblique muscle. So, again, the way the superior oblique muscle attaches to the eye, when it contracts, it will pull the eye upward, causing the eyeball to rotate downward. Okay, so that's the trochlear nerve. The trigeminal nerve is what we classify as a mixed nerve, and this is our first example of that. A mixed nerve is a nerve that has both sensory and motor functions to it. Um, and it originates in what's called the trigeminal nucleus of the pons. So now you can see we're working our way down the brainstem, becoming more caudal. Now, it's much more heavy to the sensory side than the motor side. The trigeminal nerve has three distinct branches that project out to different areas of the head. The most superior branch is called the ophthalmic division, or what's called V1. The middle branch is the maxillary division, V2. You can probably have an idea of where that branch is going to go to. And then there's what's called the mandibular division, called V3, and this is where it gets mixed. So you can see V1 and V2 are sensory in nature, and the mandibular division is mixed, both sensory and motor, and I'll talk more about that on the next slide. From the sensory side of this, all three divisions create what are called facial dermatomes. Dermatomes are skin maps. So basically, sensory information from our skin, touch, temperature, and pain, project from specific areas of the skin to specific areas of the central nervous system. And I'll show you an image of that in a moment. And from the sensory aspect, they terminate in the pons and then continue from there to areas of the brain so we can analyze that information. From the motor aspect of this, the trigeminal nerve innervates muscles of mastication such as the temporalis muscle, the masseter muscle, and the pterygoid muscles. So remember, the temporalis and masseter cause elevation of the jaw, causing you to close your mouth, and the pterygoid muscles cause medial lateral rotation of the jaw. And then also the anterior belly of what's called the digastric, mylohyoid, tensor valley palatini, and a muscle that's associated with the middle ear called the tensor tympani muscle. All right. Now the trigeminal nerve, in saying that, if we look at the picture on the right here, you can see these colored here. These are the dermatomes I was talking about. The ophthalmic area, that's called V1, the maxillary area, V2, and then the mandibular area, V3. All right. So basically, the sensory nerve endings associated with the trigeminal nerve in this area, these collect sensory information from the skin in these areas and then project it inward towards the pons, which will continue into the brain so we can process touch, temperature, and pain associated with these parts of the face. Because there are no spinal nerves that get up this high in terms of dealing with dermatomes or skin maps of the face, so we rely on the oculomotor nerve for this. And then, like I said, the motor aspect of this, like I said, this plays an important role in innervating muscles of mastication that I mentioned in the previous slide. So that's important because if people have damage to this nerve, depending on which branch is damaged or the overall nerve, they're going to have impaired or loss of sensation in parts of their face. Now, for example, if someone only had loss or impaired sensations on as you can see, like in the upper bridge of their nose or on their forehead, that's going to tell you that the ophthalmic branch is damaged, but if senses are normal in the maxillary mandibular area, those are still intact. All right. If people have damage to this nerve, they're going to have an inability chewing. They're going to have they could have an inability to rotate their jaws side to side. They could have partial deafness due to the fact because that tensor tympani muscle helps control tension of the tympanic membrane, your eardrums, for us to accommodate sounds. So as you can see, there could be a lot of things that can go wrong depending on, again, which branch of this nerve is damaged and what function does that branch govern? Is it sensory or motor? And again, if someone also has damage to this nerve, they're going to have an inability or an impaired speech because, remember, muscles of mastication are about more than chewing. That's what I'm currently using to bore you to death with so I can yak at you with this lecture. All right. Cranial nerve number 6, the abducens nerve. Purely a motor nerve, and it innervates a muscle called the lateral rectus muscle, which creates lateral rotation of the eye. There's a nucleus in the pons, right at the base of the pons between it and the medulla oblongata, called the abducens nucleus. Now, the lateral rectus muscle, it's the name, it causes the eye to deviate laterally. So basically, if someone has damage to this nerve, they're going to have an inability to rotate their eye laterally. If one of these nerves are damaged, you're going to see they have one eye, both, it could be both. And what's going to happen if the lateral the lateral rectus muscle, if you can't use it, then the muscles that control medial rotation of the eye are going to basically overpower or take control, I should say, and that's going to cause the eyeballs to deviate or rotate inward or medially. Um, this is why let's like a moment to pause here for a moment. Moment to pause here for a moment. That's a lot of moment. But if you think about this, like if you're a fan of football, like American football, for any foreigners that are watching this, it's a physical sport. There's a lot of head trauma, there's a lot of concussions, there's a lot of just negative effects of that sport on athletes. I shouldn't laugh. I'm sorry, but I played football for many years, so I understand that. But like you notice when someone takes head trauma, there's always you see these basic clinical tests that physicians or practitioners conduct on people, whether it's a physician, nurse, a paramedic, because for example, if people take trauma to the head and there's swelling, there's inflammation, or just direct damage to these nerves, you're going to see you can directly test this. For example, if someone were to have their abducens nerve damage, you see these practitioners do these follow the finger tests, where they say to look at their finger, and they move their fingers from side to side. And if their eyes can't follow that, they tell them to, basically keep their head still, but just, follow the finger with their eyes. You can see damage of these cranial nerves just by simply doing a test like that. And that could give an indication of where the trauma has occurred. If there's a tumor in a particular area pressing on, a root of one of these nerves, there's a lot that you can get. A lot of information you can get just from doing a basic physical test like that. All right. So again, if people have damage to that lateral rectus muscle and there's the medial deviation of the eye, that could cause double vision, diplopia, difficulty focusing, and so on. Okay. That's the abducens nerve. Cranial nerve number 7, the facial nerve, a very, very important nerve, also mixed in nature. There's sensory and motor aspects of this. The main sensory things to focus on here with this are there's input from the anterior 2/3 of the tongue. So obviously there is taste information that's projected from the tongue through this nerve to the central nervous system, and also skin around the external acoustic meatus. Remember, that's the opening of your ear canal. And the motor aspect of this innervates muscles of facial expression. And there's a lot of times when you're learning anatomy and physiology where you just have to turn your damn brain off and just take things for what they are. Don't overthink what the facial nerve is and where it goes. It distributes to the face. So it helps control muscles of facial expression. There's also parasympathetic innervation of what are called your submandibular and sublingual salivary glands, and also your lacrimal glands. Lacrimal meaning tear-secreting glands. They're damage to this nerve. There could be a variety of effects from this, depending on which branch. If it's damaged more toward, if you see impairment or damage towards the root of the nerve, you're going to see a lot of these functions affected that I just mentioned. If there's damage to a specific branch, you're going to see a more just specific function affected by this. Obviously, there's simple ways you could assess damage to this nerve. If there is damage to the sensory aspects of this that are associated with the tongue, they're going to have a difficult time analyzing sweet and salty flavors. So if you took like a Q-tip and put something sweet or salty on it, dab the anterior side of the tongue, they're going to have a difficult time analyzing those senses. If you took like an ammonia swab and got it close to their eyes, ammonia really irritates the cornea of our eyes, so that causes our lacrimal glands to secrete tears to wash our eyes out. They could have an inability to generate tears. Or there could be impaired facial expressions as well, depending on, again, which branches are damaged. And oftentimes you see a condition called Bell's palsy, which is, damage or sort of, idiopathic paralysis of this nerve, which causes people to, it kind of looks like a stroke in a lot of ways, where it causes the facial muscles to become paralyzed, causes skin to become very flaccid on one side. A lot of times, very reversible condition. Oftentimes, is associated with like Graves' disease and things like that, or just trauma to that nerve. Now, however, though, this is a very, very important nerve. What's kind of cool. So if you look at this picture right here, this is a little cleaner than the previous one that I had. you can see that there are branches of this nerve that project to specific areas of the head. When we're looking at the facial nerve. Now, when we look at the facial nerve, there is a cervical branch that has, remember the word cervical literally means neck. So there's a cervical branch that goes down towards the neck. There is a mandibular branch that goes towards the mandible. There are temporal branches that head up more towards the temples. There are zygomatic branches, and there are buccal and maxillary branches as well. So what's interesting about this, the way this maps out, if you were to take your right hand, put it up next to this face in front of you in your computer screen, and just gently spread your fingers apart from one another. What's interesting about this, these branches almost perfectly follow your fingers on the side of the face. I say your right hand because the way your thumb projects down towards the neck maps this out. So, like I said, if someone could just potentially take damage to one of these branches, and they're going to have an inability to, control muscles in those areas, and like I said, cause facial expression issues. So, but that's essentially the facial nerve. Cranial nerve number 8, vestibulocochlear nerve, a sensory nerve that's very important in hearing and balance. These originate in the cochlea, which is the organ of hearing within the inner ear, and what's called the vestibular system, which is a system of semicircular canals full of fluid, which basically have fibers that terminate within the medulla oblongata and the pons. Damage to these nerves can cause hearing impairment. It's called nystagmus. It's kind of rapid back and forth movements of the eyes, nausea, vertigo, which is the fancy term for dizziness, loss of proprioception, balance issues, inability to walk straight. Sorry for the kind of cheesy images here that I had to take. So, realistically speaking, what the vestibulocochlear nerve is it's two separate nerves that fuse and carry sensory afferent information towards the brain. So that right there is the cochlea, and then these are part of what's called the vestibular system. So there are nerve fibers that project from the internal parts of the cochlea, and then you've got nerve fibers that project from the internal parts of the vestibular system. They meet as one and then project towards the brainstem together. So we've got both hearing and balance about or information about body position heading towards our brain together. So if you see damage to this nerve after the convergence, of the cochlear and vestibular nerves, then you could see both hearing and balance issues, nausea, vertigo, things like that. If there's damage more with just specifically the vestibular system, then you're going to see those more physical effects. If it's more with the cochlea, you're going to see more of the hearing impairments that are associated with it. Now, again, always remember, hearing impairments aren't just damage to this nerve. That could be They could be stemming from problems with the tympanic membrane. Could be problems centrally with the brain. That's why there's various clinical tests that have to be performed to figure out what's going on. Like, for example, when you do like Rhine tests with a tuning fork and so on. All right. So that's cranial nerve number 8, and that's something you get more into is in depth with the special senses as well. Cranial nerve number 9. This is one that's definitely going to come up in the near future, especially in Anatomy 2, when you learn about the blood pressure and temperature regulation and all that stuff. Glossopharyngeal is a mixed nerve as well. So the sensory aspects of this deal with senses from the posterior third of the tongue and the posterior parts of the palate. So when people have damage to this nerve, again, they're going to have an impaired sense of taste. They could have a difficult time analyzing more sour or bitter taste sensations. And also there are branches from the carotid sinus, which is a bulbous kind of part of the internal carotid artery that analyzes blood pressure and blood chemistry to help us regulate our blood pressure and our ventilation rates, breath rate. The motor aspects of this nerve, this innervates various muscles of the pharynx and larynx. Basically, muscles we use for swallowing, what I usually refer to, well, not I, but books as well refer to as pharyngeal constrictor muscles. And there's also some autonomic as well. There's parasympathetic preganglionic neurons that innervate parotid salivary glands, the other third major type of salivary gland as well, the largest of them. The roots of these are in the medulla oblongata, and the sensory aspect of this branch from the pharynx, again, the posterior third of the tongue, and the internal carotid artery. Again, when I said root in this first one, I meant motor. Sorry. Now, when people have damage to this nerve, again, depending on where the damage is occurring, they could have impaired taste sensation, they could have a difficult time swallowing food, and an impaired ability to regulate their blood pressure. So again, you're going to learn about this more down the road, especially in A&P2, when we learn about how we regulate blood pressure and breath rate. When you learn about the visceral sensory aspect of this nerve in terms of how it gathers information about, when I say blood chemistry, I'm really referring to pH of our blood, and also blood pressure, because if our blood pressure spikes, the walls of the carotid sinus will expand more than normal. If our blood pressure were to fall rapidly, then that would cause the walls to collapse, and those nerve endings associated with that area will detect this. But yeah, so that is the glossopharyngeal nerve. Like I said, that will come up again. And then this bad boy right here, cranial nerve number 10, the vagus nerve. As I mentioned at the beginning of this video, no cranial nerve after this will be mentioned more than this thing right here. Mostly because this nerve makes up the majority or the bulk of the parasympathetic nervous system. To be a little more specific, the majority of preganglionic parasympathetic neurons stem from the vagus nerve. Now, the vagus nerve is called this because of how it projects away from the brain. The word vagus is Latin for wandering. Now, as I mentioned at the beginning of the video, cranial nerves, for the most part, are associated with sensory motor functions of the head and the neck. With the vagus nerve, this is a mixed nerve. It's called, well, you'll see why it's called this in a moment, because of how far it wanders away from the head of the neck. And this is hands down the most extensively branched cranial nerve of the bunch. The visceral motor root of this is in the medulla oblongata, called the vagal nucleus. The somatic motor aspects of this deal with the pharynx and the larynx in terms of, like I said, dealing with making adjustments to the tension of vocal cords and things like that, because as you'll learn in a little bit, that impairment of this could cause a person to have a hoarse voice. And then sensory aspects of this, also sensory parts of the functions associated with the pharynx and larynx, and so many visceral sensations because of how extensively branched this nerve is with our internal organs, especially with cardiac and smooth muscle and various glands of our internal viscera. Damage to this nerve can cause an impaired ability to swallow. Like I said, it will cause a hoarse voice, and at the extreme level will cause a slight case of death if both nerves were damaged or cut. Now, so look right here, the vagus nerve. Again, this is a not so good picture. I apologize, but when you look at the vagus nerve right here, like I said, this is why they call it the wandering nerve, because of how far it travels down through the thorax, it travels down through most of the abdomen, and exhibits parasympathetic innervation of so many internal viscera along the way. Now remember, something to always remember about the parasympathetic nervous system. Associate this quirky little phrase with it: rest and digest. This is what keeps your body at basic resting, in a resting state, we'll say. This is what keeps your heart rate at resting levels, keeps the bronchioles in your lungs constricted to have airflow match your resting metabolic needs. When you eat food and your GI tract is full of a bolus of food, the parasympathetic nervous system increases gastrointestinal motility, gastrointestinal secretions, and things like that. And like I said, the vagus nerve is going to come up a lot more in many other areas moving forward. So like I said, I don't want to go crazy with it right now. But also, actually something to think about as well. Have you ever wondered why, this is a morbid example to use for this, but a practical one nonetheless. Have you folks ever wondered why a person could have a transected part of their spinal cord in their neck and still live? Because one thing you always learn about damage or trauma to the spinal cord, a rule of thumb with it, is whenever people have damage to their spinal cord, the rule of thumb is you always lose function everywhere below the site of damage, where the spinal cord has been cut. So, like for example, people that have neck injuries obviously are going to become quadriplegics. They're going to lose function of all four limbs. And if the damage is high enough, they may also lose function of their diaphragm if the damage is above the phrenic nerve. But yet, why can they still digest food? Why can they still regulate their heart rate and things like that? Well, it's because of the vagus nerve. The vagus nerve bypasses the spinal cord and sends signals out to these very important internal organs, these thoracic and abdominal viscera. This bypasses the spinal cord. The brain gets this information out, these visceral motor signals to these important internal organs without having to pass through the spinal cord. So a person's vagus nerve can still keep them alive after their spinal cord has been damaged because of this. I don't know if this is something anyone's ever thought about, but I remember when I was a student and before I learned any of this stuff, I always wondered that, and this, obviously solved that mystery. So yeah. Cranial nerve number 11, the accessory nerve. This is a motor nerve that has both roots in the medulla oblongata and C1 through C6. So there's some spinal cord rootage here. That's well put. This basically innervates muscles of the upper trapezius and the sternocleidomastoid muscle. Remember, a muscle that has its origins on the manubrium of the sternum, the medial third of the clavicle, and inserts on the mastoid process, that prominence behind your ear, or I should say behind your external acoustic meatus. And remember, these muscles are all about neck and shoulder movements. The sternocleidomastoid muscle, when contracted unilaterally, causes lateral flexion of your neck. When contracted bilaterally, causes total flexion of your neck. And the upper trapezius muscle causes you to elevate or shrug your shoulders. So when people obviously have damage to this nerve, if it's just one nerve, they're going to have an inability to shrug their shoulders on that side where the damage occurred, and they're going to have a difficult time rotating their head, and their heads tend to deviate towards the side of where the damage took place. So that's something you can actually see. So if you look right here, this is the sternocleidomastoid muscle right here, and that is the upper trapezius muscle right there. So, I don't know, accessory nerve's pretty cut and dry. Again, motor nerve. And the hypoglossal nerve, a motor nerve as well that stems from the hypoglossal nucleus of the medulla oblongata. It innervates intrinsic and extrinsic tongue muscles. These are three major extrinsic tongue muscles that are listed here that play an important role in tongue movements. And when people have, so this is, being that this is a motor nerve, this basically helps us, this is the nerve that controls tongue movements, all right? When all the other nerves you encountered so far that were associated with the tongue were associated with sensory functions of the tongue, analyzing, or I should say, detecting taste stimuli. Now, when people have damage to this nerve, they could have an impaired ability to swallow because their tongue plays a crucial role in swallowing. They could have a difficult time protruding their tongue, and you will see deviation of the tongue if one of these branches are damaged, which you can see right here in this image. And you can see right here, these are the muscles that I mentioned right here that are extrinsic tongue muscles that help with tongue movement. So like when you go to swallow food, remember your tongue is a muscle. So when you internally contract it, you notice we tend to put the tip of our tongue on the roof of our mouth, and our tongue balls up on the back of our oral cavity. That's how we push food towards our throat, towards our oropharynx, so we can actually swallow it. Then we use our pharyngeal constrictor muscles to continue to push it downward. So that's why when someone does have damage to this nerve, they're going to have a difficult time swallowing. Now, what's going to happen if only one of these side of the pair is damaged, what you'll see is the tongue deviate towards the side of where the damage occurred. So being that the tongue is deviating to the left, the left of the pairs damaged here. So when people go to stick out their tongue, what'll happen, they will not be able to stick out their tongue in a straight fashion and protrude it out of their mouth. So that's unilateral damage. If they have bilateral damage to both branches of this nerve, they will not be able to protrude their tongue out of their oral cavity at all, which will again create impaired swallowing. It will create impaired speech. and so on due to the basically inability to control tongue movements. Okay, so again, this lecture was a basic overview of cranial nerves and cranial nerve function and some basic clinical implications of damage or impairment to these nerves. I hope you folks found this helpful. Like I said, down the road, I will create a more comprehensive one that has to do more with like I said, the projection pathways of these nerves associated with the cranium, how they enter and exit the cranium, the foramina, and so on. Thanks for watching, and take care and have a good one. That's all I got.